Thanks, you guys. That quick response. Very excited to have Katie Coleman here. She's going to say a little bit about her recent history. She has a big fan club here. If you're not a member yet, you will be soon. She is not going to rap, however. I asked her not to rap today. 1 rap per day. So, cut off. Interpretive dance next, yeah. Next time we reconvene, we'll do that. So here you go.
Thank you. Hi. I'm Katie Coleman. I'm from the McCall Center for Healthcare Innovation in Seattle. We're part of Group Health Research Institute. Most people know us as Ed Wagner's shop, or the shop where the chronic care model was developed. So that's all us in that group. We sit inside a research organization, but do a lot of practice-facing support. So I work with my colleagues there on a variety of initiatives, most recently with many friends in Oregon on the Safety Net Medical Home Initiative, where we were supporting 5 states that were working with practices to become medical homes. And then, as you all know, kind of that work influenced the advanced primary care practice demonstration and some of the work from CPCI that was coming out of the Center for Medicaid and Medicare Innovation. So it's been a fun time to be in primary care research, right? It's been pretty great these last couple of years. So today we're just going to take a little time to facilitate a conversation about what the research tells us about how best to support practices in becoming patient-centered medical homes. And I'm going to tell you right now that for the questions you actually want answers to, research is not going to help us, right? Like, how do I get that really reluctant practice on board? That kind of thing. We're not going to be able to answer with good p-values and statistics. So let's have a conversation about what we all think works and what our experience shows as well. So we talked a little bit this morning about what you all are doing with practices, but why are you doing it? What are you hoping to achieve with all this effort you're putting in?
You want an answer to that?
Yeah, I want an answer. Better care. What does that mean?
Better measures, sort of clinical measures.
Better clinical measures, right? Like intermediate health outcomes. We want people to be healthier. We want them to have lower blood sugar. We want them to have better heart health, right? Clinical measures. What else?
We want them to have joy in work.
Who to have joy in work? Us to have joy in work. We have RAPs. That's what we do. Who are we talking about?
The providers and support staff and nurses that work in the clinics.
Okay, so there's this workforce development piece, partially because we want people to go into primary care, right? Like we want that to be a viable career, and also because we want that workforce to stay and to grow and to support our communities. What else?
We want it to be sustained, like we're empowering, so that the work we're doing with them isn't just because they get help on a project and then when the project's done, it's done. It's kind of empowering them to have the skills they need to function as a team.
Like building capacity for like this ongoing capacity building empowerment of the clinical team. I thought you were going to say the patient.
That too.
Right? Because you're all patient-centered over there, right? But right. What else?
Happy patients.
Happy what?
Happy patients.
Happy patients, right? Happy, healthy, right? So these are all data that speak to what you just mentioned, right? Here is some information talking about who's going in to primary care. And this is an area of particular concern as we expand access with 2014 and 2015 coming, right? That we're looking and we're saying, wow, there are a lot of people that are choosing other specialties and not going into primary care. And we've run some collaboratives working with academic practices, and we say, why are people not going into primary care? And a lot of the residents say, you know, we walk into a primary care practice, and I don't see that I would be able to succeed there. The patient needs are too complex. People are too sick, and I don't have the support I need in that practice environment to be successful. I can go be a hospitalist and I will be successful in that setting, right? So the work that we're doing around patient-centered medical home is critically important to show that primary care can be successful and can be a place that people want to work. So this is looking, the blue bar is 1999, the purplish bar is 2009, and we're looking at the percent of folks that are going, choosing family practice, general internal medicine, and pediatrics. Here's another thing that you talked about, right? So you were talking about over here improving clinical quality of care. The demographics of folks that are seeking primary care is changing. There's more patients with more illness that's coming into primary care. And we've tried all these interesting innovations, ambulatory ICUs, we're gonna carve out disease management, these are all programs in an attempt to recognize the changing demographics that are coming into primary care and to do something to help manage these clinical quality improvements. But I'm gonna tell you, this capacity has to exist in primary care. For primary care to continue to be relevant, primary care has to become expert at managing complex, elderly, geriatric patients. That has to be part of our expertise as we go forward in primary care. This is the other piece, right? Someone said joy in work. We want primary care staff and physicians to find joy in work. This is from a study that looked at in a standard panel of patients, right, in 1,400 patients, standard size panel of patients. If we delivered all the preventive care needs and all the evidence-based care needs, so these are things like, secondary prevention, like getting hemoglobin A1C tests and the like, how much time would it take a provider in a practice to deliver all the preventive care and evidence-based care needs in a day? And the good news is it's not over 24 hours. But the bad news is it doesn't include acute visits in here, right? With people like a sore throat. So there's that piece too. So we're looking here at about 18 hours a day for a provider to do this. It is not tenable for one doctor to meet all the great metrics that we know we want to have in primary care. They have to have a team, and a lot of you talked about team-based care development, RNs, MAs, upskilling. What does that look like? That sort of thing. And then someone talked about we want our patients to be happy. Right? And this is old evidence, but sad evidence that is still the same. Half of the people leave the doctor's office without understanding what their physician said. And doctors recognize this. They say only half of doctors say that people with chronic conditions usually receive adequate medical care, right? So there's this sense that we're not doing all we can for patients currently in primary care. So these are the many and varied reasons that you all are working with practices, and this is like where the primary care patient-centered medical home came from, was look at all of these things that we can improve. So the question is the medical home the answer? Do we think the medical home can change these things? We hope. We're spending an awful lot of time on it. We sure hope it is, right? Anybody have any kind of evidence that we think this makes a difference? From your work? Anecdotal. You see when anybody seems happier? Yeah.
Sure. I've seen people implement just something like depression screening, find suicidal patients that they recognize they would never have found, and just from that anecdote, compared to when they used to work in practice that didn't do that, and say, wow, I feel so much better about the care that I give here.
Putting PHQs in place in a primary care setting, all the undiagnosed mental health needs, right?
Training nurses to provide care management. We saw a significant improvement in the diabetes bundle, so blood pressure, LDL, and A1Cs under control.
So we're seeing changes in clinical outcomes, which is awesome. Yeah.
Referral tracking.
Okay, this is huge, right?
Yeah, no, they had no tracking. They knew that they said you need to go to the cardiologist, but then, oh well, now it's up to you.
Right.
Yeah. So
And a patient satisfaction piece. I mean, you talk to people about what's wrong with healthcare, and they will tell you some story about managing their parents and not knowing where to go and not being able to get an appointment and having duplicative tests and all this, right? Yeah.
Behavioral health integration in the community.
Right. Right. Huge.
Better partnering with parents. We have some of our practices for the first time kind of pulling parents in as partners in quality improvement they're doing. They were designing care plans and never actually asked the people who did care plans before, does this make sense to you? How do we make this more valuable?
Right.
And then we've also seen an increase in the teamness of our practices.
Within
We've
the
been
practice.
asking it before every learning session, and it's kind of this elephant in the room of like all of our individual efforts aren't going to work if they're not a team, functioning as a team.
Right.
And that's gone up as a kind of side impact, but probably a primary.
This patient engagement piece is huge, and we need to talk more about that because the evidence doesn't talk much about that. So here's what we know from the literature. This is from a report that came out in 2007. This is done by the Commonwealth Fund, which is a big foundation out of New York City. And they survey adults regularly and ask them a whole group of questions. And they asked, these are the % of adults who say they get the care they need when they need it. And they compared people that had the characteristics of a medical home, people who have a regular source of care, meaning they know that who their doctor is, but it's not a medical home, and people with no regular source of care. And you can see there is dramatic improvement in the patient perception of them getting the care they want. So what is their definition of a medical home? Their definition of a medical home, because you know there are 5,000 definitions of a medical home, their definition of a medical home is if a person can say, I know who my doctor is, and I don't have difficulty getting to my doctor on the phone during business hours, and I don't have difficulty getting some sort of care after hours, and when I show up, the practice seems like it's pretty well organized and running on time. Those are their characteristics of what makes a medical home. What percentage of people you think answer yes to those 4 questions? That they surveyed. This is, right? This is a random survey of adults in America. How many people answers yes to those 4 questions? 10%. We got some pessimists going on over here. We got 10%. 10% of people are like, if things are kind of running and I can get in and I can follow up after hours and I know my doctor. 10%. Who else? Thank God. Who said that? 50%, right? It's actually 27%. 27% was they found. You were there, right? But this is the low bar definition of the medical home, right? We're talking the low bar definition. How many characteristics are there in the patient-centered primary care, right? Not 4. But we know it makes a difference, even with just those four characteristics, that a medical home makes a difference in patients' perception of care. Now, as you guys also know, there are a jillion medical home interventions going on right now. Many of them have not been evaluated. Some of them are, still going on, like the ones you all are working on. But this is a meta-analysis that was recently conducted, July last year. It was published, evaluating the interventions that have already concluded and that had a peer-reviewed evaluation of them. So they had robust data and they did something like a randomized trial, or they had some other strong data that they used to evaluate components of the medical home. So these are medical home interventions, and you can see they had 17 studies to look at, and 7 of those studies looked at patient and caregiver experience, right? Like we want patients to be happier. And the great news is that across those studies, they found improvements. Now, the strength of all those, they didn't have great data for all of them, so the strength of that is moderate. 3 of the 17 measured staff experience, this idea of retention, joy in work, and the good news there is that they saw statistically significant improvements. Care processes, right, this is the clinical measures. Improvements, again, the strength on all of these isn't great, but it's very promising that we're looking at medical home interventions and we're seeing that we're improving on the areas we care about, which you talked about: caregiver experience, staff experience, care processes. And here's the one that payers care about, and we all should care about, because healthcare is eating up more and more of our GDP, right? These are cost and utilization measures. So we're looking up here, and we are looking out of the 17 studies. 5 look at inpatient admissions, 3 looked at ED admissions. And you can see that there is improvements in both inpatient admissions and ED admissions, especially among our older adults, our more complex adults, which we would expect to benefit from these kind of services, right? They're not huge results, and they're only really statistically significant among this group, but we're seeing improvements in utilization. Now, these are all trials. Here's some observational studies, and you can see pretty big improvements here. These are less rigorous types of studies. But 29% reduction in emergency department visits. CCNC is Community Care North Carolina. These are safety net populations, right? Medicaid populations. 8% ED visits, 18% Medicaid kids with asthma getting admission to the hospital. These are quality metrics. These are utilization metrics. Question is, are these going to translate into cost metrics, right? The evidence from this review is that we're not seeing an impact on cost yet. But we're seeing some promising movement on utilization. So this is good news. Hit it.
Can you speak to that? I'm guessing that's behind it, but I'd like you to. Two questions. One is the difference between the 29% and the 8%. What was so different in those two?
Yep.
And then 29% and 11% is a huge drop, and there was no cost change. So what's going on?
Okay. So the difference between 29%, 8%, and 8%, these are different populations studied, right? This is in an integrated delivery system in the Pacific Northwest. This is an integrated delivery system in Pennsylvania. They have different demographics, older populations, younger, and this is in a safety net population. So we can't generalize too much, but It's more the direction that we're looking at, that we're seeing. Who can posit to guess why we would see reductions in utilization, but maybe not see cost reductions?
Because they're going to the clinic instead, so it's not completely taking away the cost, it's just moving the cost.
Okay, so there's maybe there's a cost shifting thing. You go to the primary care practice 3 times instead of the hospital once, okay?
You do use some of those resources, but a lot of the benefit is not, I mean, these were all short-term studies, yes?
You are exactly right.
So the benefit is out sometimes 18 months, sometimes 3 years, 5 years.
The biggest trouble of these studies is they're like 12-month, 18-month follow-up, right? So you could maybe see that the first wave of people isn't going into the hospital as much, but you can't see the full weight of the cost savings because they're so short-term. So there's definitely a methods issue here, right? What else?
I mean, one of the things in Oregon is we're doing kind of a one-size-fits-all
Yeah.
medical home. So, for example, for children, they're more like, getting them in for well visits, like kids. Whereas if we did a medical home that was just specific to people with chronic conditions that were high cost, we might have more of an impact on cost. But because we're trying to actually achieve the triple aim, which cost isn't the only thing, there's some dilution of factor, and there's actually more engagement in healthcare for people that may not even need been engaged in healthcare, period.
That is exactly right. So one of the studies that we looked at in North Carolina among safety net populations found costs went up because people were getting access to care. They were getting the proactive planned care outreach because they had panels and they were doing proactive outreach and they were bringing people into care that were sitting out there sick. Well, you guys know in Oregon, you're the Oregon Health Insurance Experiment. You guys are leading the nation on this evidence. You know when we bring people into care, they get better, but it's more costly, right? So one of it is we're providing better access and we're providing people with better opportunity to get access to care, but that costs. There's a short-term follow-up. What else?
Diagnostics. I mean, because you're outreaching and you're getting your people into their services, they're still, they're finally getting those diagnostics.
Right, so there's that access question, right? People are coming in and using services more as part of it. That's true. You guys haven't mentioned the big one. Don't even say it, Mindy. The big one in the room. Yes.
Well, these measures are all behavioral type components, which traditionally take longer, as Dr. Salino was saying.
Right.
So some of the other measures that you may look at that may be better are more specific for like the people who have asthma that are getting proper medication, and people with skin disease that are getting asthma therapy, which is more short term. These behavioral are much longer to take effect.
Right. So there's that methods piece.
And there's also startup costs with these type of programs.
Okay, so now we're starting to get close, right? You cannot build a patient-centered medical home, put $20 million into their patient-centered medical home, okay? They wanted to reduce panel size because they said, if we really want to do this thing right, we have to have a manageable panel size. You can't impanel a doctor with, 2,800 patients and say, we would like them to all have great quality outcomes. Go forth, right? So we reduced panel size. Well, that means we had to hire doctors, we had to hire nurses, we had all this upfront cost. Why didn't we save it on the back end?
All the reimbursement system is exactly the same, and so even though you're in a closed system like that, you're still in that same environment, which doesn't foster that.
Price. When we renegotiate with our partners and we say, hey, aren't you proud of us? We're going to reduce admissions to your hospital by 12%. Aren't you glad? Our hospital partners, we're going to send fewer patients your way. They say, great, you want to have access to our hospital? We have to keep our beds. We have to keep people here. We have to have staff. We have to admit your patients. We will increase your prices. You're going to admit fewer patients, but they will pay more, right? There is a price problem here where you can reduce utilization on the front end and you invest in all the startup, and then you have to negotiate price. And there are other people downstream that need to make a living wage going on in the specialty care arena, in the hospital arena, in the diagnostics arena. It's a very complicated system. And so the question of how can we drive down costs, which is something that some people are really invested in the medical home, is going to be a sticky one, because I think we can hold primary care accountable to reduce utilization, because this is good care, but I'm not sure we can hold primary care alone accountable for reducing total costs. That was kind of a side tangent. Anybody else?
No, but it's,
Hit
this
it.
is back to the payer conversation. I think it feels very fair to monitor utilization.
Right.
That's really clean, and what people charge on the backside is not our job. I mean, I think, I think the more we monitor utilization, and we notice that costs continue to increase.
Right. Anyone wants any of this, go read the very depressing New York Times articles that have been coming out lately, yeah.
So I think that hospitals want to be kept whole.
Exactly.
For a while. Somebody has to give for the cost savings to be returned back, like Donald Berwick wants us to.
Right.
Somebody has to give. And people still want to be whole, but their benchmark is the old inefficient system.
Right. And I think you're exactly right. And I think this is why that next ring you were talking about, getting outside of primary care, now we got to start talking about specialty care. Now we got to start talking about that next ring outside. And how are we going to do that? How are we going to make the care coordination work? You were going to say something.
Well, I was just going to comment, when you talk about costs, it's cost savings to whom?
Right.
And when you're really talking about developing, putting all the resources, there's a lot of cost to doing that, and you may be saving money for Medicare.
Right.
And in fact, we've shown that you can do that.
Right.
But it doesn't get translated to saving
Back to
costs
primary.
back to the primary or to the medical home. And so that's where we need to be more creative about how those costs are determined, and then who gets to share in that.
And that is not a joke. Just even determining who and where the funding accrues and that sort of thing, there's a lot of interesting methods work for people to figure out the cost part. Anybody else want to talk more about costs, or should we move on? I mean, I could talk costs all day long. Hit it.
You mentioned New York Times articles. There was a series they did about hospitals buying up ambulatory cares and then charging a facility fee for procedures that were traditionally
These
done.
are our ACOs. Those were supposed to reduce costs.
Right, and so now we're paying much more for the same procedures.
Bringing them in-house because we're reducing hospitalizations. They've got capacity.
Well, and I heard you at one point just mildly vent about the primary care being responsible for all the costs of the, I mean, that's kind of crazy. Somehow we've taken it on because we're all such hard workers, we really care about patients, and it's not our fight alone.
Right. I mean, right. Not our fight alone. I think that's right. Anybody else? Okay. So the question is, how are we going to get from where we are to where we want to be? How are we going to get from the care that is currently going on to that care in these studies that's showing improvements? And we're doing it right now through the work that all of you are doing. I thought this was hilarious. Consumer Reports in July of 2013. Did you guys see that? They put out that table like, here is what the patient-centered medical home is for like general popular consumption. And this one is edited slightly, but I loved it. I thought it was, a great tool. So if anybody's trying to explain what the medical home is, check out Consumer Reports, July 2013, right? So how do we support transformation into primary care homes more effectively? And I'm going to go just quickly through what some of the evidence is around primary care practice support, of which this is a growing field and there isn't a whole lot, and much of the field is being developed here by our colleagues in the Rural Health Network. So how many of you guys know about Dartmouth Clinical Microsystems, right? Yeah. Dartmouth Clinical Microsystems is a great suite of tools. If this isn't something that's in your toolbox or on your radar, write this down. Dartmouth Clinical Microsystems. They've done a tremendous amount of work on developing tools around primary care practice transformation. And one of the folks that was kind of a founder of this was a gentleman named Paul Batalden. And Paul Batalden and Don Berwick and Ed Wagner are the guys that I think of as like the old lions of like primary care practice reform, right? And so Paul Batalden's written a tremendous amount about how do practices make change. And he developed this kind of easy formula, which I think is interesting, and I won't belabor, but it will provide a framework for the rest of our conversation. So basically what he says is you have to have generalizable scientific evidence, right? These are the changes you want the practice to make. We have to know that open access makes a difference. You have to know that proactive planned care and bringing people in will improve clinical outcomes. You have to have some generalizable scientific evidence. And you have to do that in a particular context, right? Like each clinic has a different payer arrangement, it's rural, it's urban, it has different networks, it has different context, right? And that can lead, so you marry the scientific evidence with the particular context, and you get to measured performance improvement. And measured performance improvement he labels as a whole thing because we have to figure out these methods issues. How do we know that a change is really improvement? What measures really matter? How long do you have to measure them for you to know that that intervention really worked? But he said this plus, that is not a joke. That's a whole thing. In fact, that's the work that most of us spend most of our time doing, familiarizing ourselves with the evidence and then finding ways to adapt it, to introduce it to our practices in all their different settings with all their different quirks and all their different leadership styles, right? And this is the work of the practice coach. This is the learning community. This is where we spend our time. We're that little plus mark right there. And this over here, this number 5, that's not a joke. That's what the practices do inside their site when they take that information you give them and they use a PDSA cycle, or they do Lean, or they do Six Sigma, and they've got their own internal quality improvement mechanism, that capacity we're trying to build on site. That's how they move forward to make measured performance improvement. So he says we have to look at all 5 of these elements basically if you want to improve practice. I'm not going to talk about them all, because we could go on for days, which would be great fun for some of us and not for others of us, perhaps in equal measure. But I am going to talk about 1, which is the generalizable scientific evidence that we know of so far around the medical home, and 4, which is what we know about how to marry that to individual context. It may be that later we decide we want more information on any of these topics, and that might be something we can talk about going forward. I went the wrong way. Okay, so here's some generalizable scientific evidence. I'm going to spend 2 slides on this. This could be like 2 days worth of work. These are the change concepts that drove the Safety Net Medical Home Initiative. These were the things that we said practices need to do to become patient-centered medical homes. We developed these 8 change concepts using literature review, environmental scan based on evidence, and a expert advisory committee, physicians, patients, policy experts, the like. We figured out that there was an order, we thought, after 5 years of trying to figure out how to implement the patient-centered medical home in practices. When we first started, we were like, here, implement these things. We have no idea where to start. Good luck. And after 4 years of practices and coaches being like, I think there's some things that need to happen first, we organized them. Interestingly, just as we're putting this together in the last maybe 3 months, there's been a piece that came out by Tom Bodenheimer, the 10 building blocks of primary care, excellent, high-performing primary care, right? And he did a bunch of case studies of excellent primary care practices, and he said, you know what I think they need to do? These are these stars. The first 3 things people need to do is they need to make sure they have data and a great quality improvement strategy, that's PDSAs or Lean, right? They have to have panels, and we have to do something about developing teams, right? And then Steve Taplin wrote a piece in the recent Annals thing, and he said, you know what, I think we've got to have a quality improvement strategy first, and then I think we need to make sure they have panels. And our work with the Safety Net Medical Home Initiative said, you know, I think we need a quality improvement strategy, and we need to do panels, and I think we need to do teams. And we're starting to see a coalescing experiential, and these haven't been rigorously tested, but an experiential kind of coalescing around the pieces when we're doing medical home transformation that we think we should focus on first, right? One of the things that was interesting about the Medical Home Initiative, and may be interesting about the work you all are doing, is that it is shaped by who is funding it, right? So we worked in Massachusetts, and they had a payer coalition who was funding it, and they wanted to see cost reduction, right? Not utilization reduction, cost reduction. So they focused on care coordination, saying this is the area where we think this is going to be, you know, the biggest leverage point for cost reduction. Do you see where care coordination is on our little order list? Let's start here. Let's start up here and see what happens, right? Well, those practices really struggled because the ones that had no quality improvement strategy, they didn't know about PDSAs, they didn't have Lean, they didn't have data, they didn't have any mechanism for that, they didn't have patient advisory committees, right? They didn't have teams. Well, who was going to do the care coordination? Whose job was that? Does that person like sit in a call center somewhere? I think we've seen the literature on that, right? I think we've seen the literature on that. How does that all work? So I think to the extent to which your interventions are shaped by the context that you're in, you have to take that into account. But I think we're starting to see that there are better and worse places to start with teams. And just to bolster that point, this is an article going all the way back to 2006 that looks at a bunch of meta-analyses, and the difference down here is improvement in hemoglobin A1C. And here's a bunch of different QI initiatives. And when they found that the biggest change to hemoglobin A1C was teams, team-based care, right? organizing teams differently. So we have some empirical evidence around some of these elements, teams being one of them, but this makes a huge difference in the way we deliver care. So if anyone's wondering where to start, what changes we should start with, I would posit to you that people need to be paneled, practices need to have capacity around quality improvement and data, and we need to work on optimizing care teams. Does that seem right to you guys in your experience? Yeah.
So you left off engaged leadership. Is that because we think that practices can do that without leadership engagement?
I left off engaged leadership because I don't have evidence that that is easily intervenable. What the intervention is. Okay, Laura's all, it's called firing, okay? That's hard because these are intervenable. We can help support. What do you do with the CEO who is like not on board? Ideas? That's a real question. Okay, we're going to do that later. We'll solve that problem next, thank God. Okay, but that's why I didn't explicitly talk about it, because I'm not clear what the interventions are. And anybody who's done work around engaged leadership, I'm talking senior level, all the way down the front line, MA leadership, I want to talk to you, right? MA leadership, all the way up, because you need leadership at every level. So people that have done that and have done that well, please, let's talk about that in a minute.
Well, I think, and I just had to
Yes.
add that I think if anything, it's more of an after the fact. All of us can probably speak to organizations we've worked with, and we can look after the fact, and if we've had less success, it's often because we've noted lack of engaged leadership. So if anything, it helps us assess our possibilities for success and the amount of effort we're going to need to put in to an organization if we kind of recognize that lack of leadership.
Right.
So it's a marker, unfortunately, and I think the strategies are really challenging.
So this is interesting, right? Using it as a baseline assessment. Using leadership as a baseline assessment to determine which practices you want to engage with, right? We're going to talk about that in a minute. So we're going to briefly talk about here learning communities, breakthrough series collaborative style, practice coaching, and written materials. What does the evidence say about these things? Learning communities. When I say learning communities and I say breakthrough series collaboratives, do you guys know what I'm talking about? Right? This is like old school IHI, right? Where you have an expert group and then you get the teams together 3 times in a year and they go home and they do their PDSA cycles and they come back and they have a celebration and they do poster boards. Yes?
I just wanted to pause. Do you find that the term learning collaborative is being butchered? And when people, because I actually do.
Speak.
The principle of learning collaborative was like shared data collection. Let's all kind of open. We're gonna create a safe environment for healthy shared competition amongst each other. You're gonna. Those are critical elements of the collaborative.
Right.
Piece. And what I find is some people think having a meeting of all the people doing QI is a collaborative, a learning collaborative.
Okay.
And that to me that doesn't actually fit the definition, which was really important when IHI was trying to figure out like how do you get practices that shared data collection, that shared use of data, that kind of holding each other accountable in a group level setting and kind of really balancing off each other was a really, really important part. And so I am deeply concerned when I hear all these words around the state right now being used of like, we're going to do collaboratives and we're doing collaboratives on this. And I'm like, I think they're just group level meetings. I don't actually think that that's a collaborative. And so what I get concerned about is that there's going to be this, learning collaboratives don't work, and it's because it wasn't actually done.
No one knows what you're
learning
doing.
collaborative.
Yeah, so that's interesting. The terminology that we use from like a researchy perspective, and you correct me if you think I'm getting this right, but that we talk about is learning communities, right, of which there's a variety of mechanisms. Learning collaboratives being one, and this is what I mean when I mean learning collaboratives, like it's a method, and it has a process, and there's a convening, and there's a certain number of teams, and they have faculty, and it's a thing. There are peer-to-peer meetings, right, which some of our practices in the Safety Net Medical Home Initiative did with great success. Quarterly meetings with a smaller group of docs and folks for 3 hours at a time. These are really costly, right? These are really costly, but under the rubric of a learning community, right? And that webinars could be part of a learning community, a listserv where you're getting together and talking, right? But that this would be a specific thing. Well, this is what I mean when I talk about learning community, or just to confuse the issue. Breakthrough series style collaboratives. So this is what the evidence says. This was a review. There have been a couple of them. The most recent one was from BMJ in 2008. And it says, we think there are statistically significant improvements in practices that participate in learning communities. There have been 9 randomized trials. 2 showed unequivocal great results. 5 showed mixed results. 2 showed no changes. And when they looked across the studies, we see about 30% of practices transform. Whole new place of being. Gone from, old school primary care, patient-centered medical home. 30% of practices bail. They don't complete the Breakthrough Series Collaborative. They don't show up for the last session, right? And 30% hold steady. Do you find these numbers depressing or liberating? Depressing. Hit it.
Realistic.
Huge investment, and that we don't do any better in sticking with the improvement process is discouraging.
It's discouraging. What else?
30% of clinics making a significant transformation in any group, that's encouraging.
You find that encouraging?
That's the exciting part for methods, because then you get to ask, well, what was it about the things that transformed, and how do we keep fostering?
Have you figured that out yet? Because that review says, we don't have any idea why the ones that succeeded, right? And that's this difficult thing, because we want to go back and be like, we're only going to pick the success ones. We're only going to pick the ones that are great. And at least according to the evidence that we have now, we don't have a foolproof assessment plan yet, right? You got to get on that.
Well, there is some through the Medicare demonstration project, started in 2002. They're continuing to follow some of the one. I thought there were 2 or 3. I mean, there are a few of them, but there are some. I think there were some learnings from those.
I agree. Does everyone know what he's talking about? Yes? You want to say a little bit more?
Well, it's just the Medicare care coordination demonstration project started in 2002. There were 15 health systems across the country that they looked at how they were able to transform the clinics or not, and whether they were able to produce financial benefits from that. There were only, I think, 3 after 4 years that they found to actually bent the cost curve and produce some positive results, and they continue to follow them and then look at them in a more qualitative way about how, what kinds of attributes these health systems have that really seem to drive the change. And in many ways, that for CPCI folks, that's really what CPCI, the milestones, are really driven off of that work over the last 10 years.
Yeah. Well, yeah.
Well, and I find it somewhat uplifting too, because if you also look, like the Center for Medical Home just did an evaluation study with their 17 practices that started, or their practices that started 17 years ago, and over a majority of them that would fall in that 30, it was more than 30% for that project, but they kept on improving. They sustained their improvements regardless of whether the project was there, because they had the fundamental capacities that were built. So the people that held out, they held out partially, I would assume, just from working in it, because they developed some of the fundamental skills, which then you're not just jumping from project to project to project to project. Instead, they have these fundamental skills that they can adapt, particularly in a state like Oregon. What our practices need when everything's being blown up is like fundamental skills to be able to adapt, because we can teach them on asthma or teach them on whatever topic. The topics are going to come and go. What they need is adaptable skills to be able to kind of function as a team and be able to do improvement. I see that as a positive, because I think those 30% are going to be able to keep going without the resources. While it's expensive on the front end, I'm hopeful that I think it's long-term cost benefit.
Yeah.
Is this consistent with other organizational change methods? Like, anytime you launch a change endeavor, I would guess that this is somewhat predictable, that you have a percentage that are going to do really well and take to it, and others that, I guess I just wonder, for learning collaborators in particular, this method, is it that different than other change methods working with any population on any topic?
I wish that I had looked at all change methods, but I didn't, and I can't answer that specifically, but I would say experientially, I think that's true. I think the other piece that's challenging about this, and one of the learnings from the Safety Net Medical Home Initiative, was the tremendous turnover. And we're talking about leadership, for example, as one of these pieces that we think is important and might be a distinguisher between the ones that are in the 30% that go on to transform and the 30% that drop out. When we look at the Safety Net Medical Home Initiative, the level of turnover was astronomical, right? Several leadership transitions in 4 years. An entire clinic's nursing staff, everyone, leaving, everyone leaving, which is both part of why people drop out, because they are like, we are in disarray, and also why people that were not on the radar to begin with end up going great guns. So there's this piece of turnover, which I think is related to wanting to have more stable workforce, more joy in work, that makes it so, both from an opportunity and a risk point of view, that makes transformation more able to happen and also less able to happen. There was last month in the Annals of Family Medicine, they published some results also, and they found a 40% of practices improved. It was like 40, 30, 20. So I think this is representative of a range, but I think it is possible that we are getting better able to understand who should be involved, and we might be able to move that number up. I, for one, find this to be incredibly uplifting, and I'll tell you why. For anybody that has gone in and sat and worked with a primary care practice, and gone in and like had difficult interactions and been there and thought, oh my gosh, I don't know if this is going to go anywhere, and felt like it was all on you as the coach, and you were going to lift this team up. This says to me, it is not all on you. You can help, you are a piece of it, but it is not all on you. There are a whole lot of other factors going on in the clinic, and you just don't need to feel discouraged when a practice drops out. I think we as coaches take it so personally when someone doesn't do a great job, and the reality is that there is just a ton going on. And there's some you're going to be able to help, and there's some you aren't, and you put your best foot out there. So I find it liberating, personally. Lori said she was depressed by it.
I think that's great. I'll say something about later. Wasn't there a study done about 3 or 4 years ago that looked at practices that they were not involved with any change effort, and that in fact 30% of them changed as well, that TransferMed study that
Exactly. She's talking about the National Demonstration Project. TransferMed, right, was supported a bunch of practices in becoming patient-centered medical homes. They were basically commercially insured family practices, generally. And they looked at 2 groups. One group got practice transformation support by a coach, and one, not even a coach, a highly paid, highly skilled group of consultants. And one got no support. And the difficulty was they did some evaluation. I thought I had the slide in here, and found that among the group that got no support, they developed their own learning community, and they got together and they did some learning sessions and got some experts and brought them in. This is the thing about motivated practices, right? Motivated practices are going to find a way to get access to the information and go forward, which is also both, exciting and speaks to the power of great leadership and capacity. Yeah.
That's an interesting point, and I also think that it's true that the programs that we have with the PCPCH and CPCI and other programs, CCOs around the state, are having impact outside of their populations, how it impacts all the, we have 400 practices, we heard, and those other 400 are being impacted as well. The CCOs are, geared towards the Medicaid population, but they're impacting the entire health system. So I think that does go beyond just the...
Absolutely. Right? And a lot of these are volunteers, right? These are volunteer practices. What happens when you do the kind of change you're talking about in Oregon, where it's geographically based? It's all practices in that area, not the ones that raise their hand and say, pick me, I really want to spend 4 days out of practice every year and, go to a learning collaborative and sit around and gather data. Right? That's a special group. When you're talking about changing everybody, that has a different implication than what the literature can guide us on. So there were a lot of challenges about Breakthrough Series collaboratives. There's a lot of challenges about getting folks together in that kind of formalized setting. One is that they're early adopters. We just talked about that. One is that they're very time intensive. People used to close down their clinics for 2 days, travel across the state or across the country in the early days, right? Get together at these learning sessions. A lot of them were large integrated delivery systems that could pay to do that. So the small practices, your practices, the 1 and 2 docs are like, no, right? That's just is not happening. And then how do we do a better job at creating supportive systems beyond that 1 year? So that led to what I think is such an interesting moment, both in the ACA around primary care extension centers, but also kind of our conversation here today. Almost all of you said you're doing one-on-one practice coaching. Right? Well, what an interesting change that has been. We used to never do that. There were consultants that did that, but we quality improvement folks, we did these learning collaboratives, right? And now quality improvement folks are going out and doing practice facilitation. So just really fascinating. And I think this practice facilitation has grown in response partially to the challenges of organizing these large-scale peer-to-peer learnings. So here's a definition of a practice facilitator that was comes out of a group that has some funding from AHRQ to start thinking about what a primary care extension center might look like. They had 4 grantees across the country that were trying to examine what that is. Do people know what I mean when I say primary care extension center? No? So olden days, this will be brief, and actually in some states, including Oregon, I think, had rural extension networks. These were, right, agriculture, right, small farms, and these folks went out and they lived at the state level and they provided support to farmers to do up-to-date farming methods, right, and it was a program to support small family farms. And the idea was, and there are a couple people that have claimed authorship of this, but Kevin Grumbach and Jim Mold being 2 of them, saying, we should do that for primary care. We should have a state-based, so you have an ongoing relationship, right? So we're not projectitis with our teams. They have an ongoing relationship, and their goal is to help primary care practices, small practices in particular, to get access to the latest medical evidence, clinical guidelines, et cetera. And those would be primary care extension centers, like they were rural extension centers for the farms. And it's actually written into the ACA legislation, but it wasn't funded. Right, it wasn't funded. So, so now AHRQ, the Agency for Healthcare Research and Quality, spent some of their money and said, well, what are some models of a primary care extension center? What would that look like? Who are these coaches? What do they do? How do they work with practices? And they awarded 4 grantees. North Carolina was 1. And so they've been developing some interesting ideas and resources. And this is a space you practice coaches might want to watch, is the primary care extension center conversation. Because I think there's going to be some interesting learnings coming here. But basically what they say is that the job of the extension center, the job of the coach, is to develop skills you need to adapt clinical evidence to the specific circumstances of the practice, right? That plus sign and the arrow sign. The job of the facilitator is to build capacity, not to present a bunch of one-off information necessarily, though that may be helpful, right? We're talking now motivational interviewing for the practice, like practices do motivational interviewing for the patients. You have to have some education, but it has to be about behavior change, right? 2, they're focused on building permanent capacity for continuous quality improvement. And so it's basically like self-management support for practices. Now, somebody was talking about being a cheerleader for practices. This is an interesting group out of Harvard that was saying, what do coaches actually do? Because you can imagine people going in and sitting and chitting-chatting with the practices and not actually doing much or generating change. And what does a practice coach actually do, right? This is a conversation I would love to have because it is not always clear to me what of those conversations are actually helpful, what. But Hackman and Wagaman talk about 3 major areas that coaches bring to the table, and that these areas need to be brought to bear at different time frames in the life cycle of a project, right? The first is motivation, that a coach, literally, one of their key jobs is to be a source of motivation. You can do it. I worked with a practice just like you, and they did it. Here's how they did that. Who's some bee pollination, bzz, right? I worked with them and they did this, and you could try that, right? Motivation. Consultation, right? Here are some serious strategies and resources that are available. Here are some implementation guides. Here are some toolkits. Here is a wrap on the YouTube video that you need to go watch, and because it will help you. You know, these, knowing the resources and connecting practices, and then education, knowledge, and skills. Here's how you do a PDSA cycle. Let's do a workshop. I'm going to teach you how to do, somebody was saying they do process mapping. Who was that? We help practices do process mapping, right? Here's how you do a process map. So there is a place for all of these pieces when you do practice coaching. What do you guys do when you do practice coaching? Bring lunch?
All of that, follow up.
Yeah.
Follow up, so we talk and then we say, you know what, I'm gonna call, we're gonna connect back in 2 weeks and let's see what's happened in that 2 weeks, I think is a really important part. Because I think if we don't do that, then it just gets buried under whatever other priorities they have.
Right? Somebody once told me the most helpful thing you did, Katie, was set up regular meetings so we could get together and solve our own problems. I was like, awesome. Awesome. Glad I have Outlook, Apparently that was all it took, right? Good, okay. But right, I mean, that is it. You have to have intentionality, regularity to their quality improvement, help them get those systems in place, follow up, totally. What else?
I think the other thing about motivation is when you show up, it creates the space within the clinic to talk about that stuff. So it's not just that you're cheerleading, which is really helpful, but it's that you give them the space, that you coming is an event that they have to be ready to talk about, and it creates an opportunity.
For conversations that frankly don't happen, right? Right?
Yeah. Well, or they never get to slow down long enough to think about those things, and you give them that time. And I mean, I've had more than one office manager say to me, Carol, I'm so glad you came over because this is the only time I have to work on this.
Right.
And it's like, all right, well then let's work on it together. Where are you at? What do we go? What do we do
Right.
this time?
But
So
that's not a joke, right? That making of the time. What else do you guys do? Yeah.
It's reassuring clinics that they're not alone in this struggle or work or whatever you want to call it, that they've got somebody else outside looking, that has their back and that's looking out for them and making sure that they're, getting the resources they need and being able to connect with others that are doing this work as well, so they're not by themselves in the silo, especially in rural communities.
Right. Because you could feel isolated.
Well, and like she said, that we have their back. If there's already that trust level with the clinics we're working with, they don't ever feel like we're judging them. That
Right.
We're really there to help them be successful. So they'll tell us things sometimes you're kind of like, oh.
I didn't hear that.
I
didn't hear that.
We're not here to talk about that. But when you build that relationship, they suddenly feel like they've got somebody that they can kind of help figure out what to do.
Right.
How do I get through all this?
Right.
And it's almost like a little therapy session.
Right. Cognitive behavioral therapy training coaches. That's next. Yeah.
One of the things I've done with our sites is after we've started them on a practice is go back and just spend a day at the site. And so that anybody who has a question about what they're trying to do can just turn around and have a free second and be like, oh, I meant to ask you. So if they're not particularly on the quality improvement team or weren't a part of the initial decision, you're just there and they can ask you at their convenience. And that's been really successful.
Interesting. Real-time problem solving. Yeah.
I was going to say that I think a lot of it is about communication and different people's learning styles. So different people might be able to learn and absorb things better via just a phone call where you're kind of explaining it in their language versus reading. And some people, listening to a webinar might be useful. So to me, it's
That multiple modalities thing we were talking about.
yeah, and they might have to hear it in my experience, about 8 different times, in different ways, using different words before they get it.
Now I'm counting on Ariel to bring up the other piece, but I haven't heard it yet, so I'm going to see.
So, one thing at least for us is an acknowledgement that the practices aren't operating in a bubble. They exist in a bigger system too, and these coaches and our facilitators, we're learning things about practices and about the process of change in a practice, and that needs to be fed back out.
Yes.
And they're an opportunity to learn at that level and affect the broader system and make policy changes based on what we're learning there. And it gets to your point earlier about, these 30% that do improve, what are we learning? Why do they improve? Well, that part of the work is important, but it's usually not what's necessarily funded or, it's people don't like to necessarily fund research on what's affecting change. I mean, it's kind of a sub-part of a bigger project that's about cost or whatever else, So just an acknowledgement that there's a feedback, there's an intent to observe and to measure and to really learn from that.
I love the way that you said that. I also, I had a colleague that said relentlessly contextualizing, both for the state, no offense, it's trying to figure out what to do next and saying, hey, here's our real experience, and for the practices where you're saying, this is what's actually happening, just that relentless back and forth kind of information.
I think at the coaching level, practices really appreciate that. I mean, it's a huge selling point. Like, oh, you're feeding this what you're learning about me back, and that might affect policies that are external drivers for me. It's huge. And the practices.
Yeah. What else do you guys spend time on with your practices?
Well, a part of our core coaching is data and measurement.
Right.
And that doesn't quite fit into any of this.
Yeah,
but
maybe
it's,
that's using good strategies, right?
Maybe,
Using your
but
data and knowing
it's
what to do.
separate
And knowledge
right
is
now,
different.
I think, in this environment with so much focus on outcomes. You know, we really have a data measurement team that has been so core in helping our clinics understand it, figure out how to get it, think about what to do with it.
Right? Thank you, Mandy.
I was just gonna say, I think one of the really fun things about doing the consultation is being able to spread things from clinic to clinic so they don't just start with a blank piece of paper. You see a leadership team or a QI team sort of swirling around the idea of something, and then you see something that Legacy started go pop up at Virginia Garcia and get mutated, and suddenly it's like a virus all over the community and the scrubbing. You know,
Right,
it's really
right.
satisfying.
The scrubbing tool is awesome. That should be shared for practices that are, I don't know what that is. What I thought you were gonna say. What were you
I'm
gonna
gonna
say?
take a guess at what you think.
Okay, what were you gonna say? What were you gonna say?
So motivational interviewing inspired to ask people to connect with their personal motivation.
Yeah.
What are they doing this for? Because it's really, really hard. And
It is.
so to try to enhance personal inspiration and motivation and to empower people to know on a really personal level why they're doing this on a day-to-day basis.
How many of you serve that role, right? Tying it back to people's core values. I thought you were gonna say team meetings and project management. I thought you were gonna say that. But this whole notion of like, we have this expectation when you do QI with practices that they've got all this infrastructure ready to go. Whereas like someone who's got the, the agenda and they've got the time and they're going to move through the, and then they're going to track the things on the data and they've got the spreadsheets and someone's, working the Excel and then you're in there and you're like, these people are delivering clinical care every day in and day out to patients. This is not like the top of their priority list or necessarily their skill set is having all of this project management, and that is a skill that we as coaches can bring and impart, and we sometimes do it like you're saying, just by being there. But it's also something we can deliberately teach as part of something you leave behind for teams. In fact, in the Dartmouth Clinical Microsystems tools, every single tool they have on quality improvement, they step a curriculum of project management and meeting management along with it. They make you try a new QI tool in the context of a new agenda tool because meetings are where the work gets done. People have to be able to meet effectively, and teams don't really know how to do that all the time. So that's another tool kit. Recent evidence supporting practice facilitation. Again, we see that recent studies show in a review of 38 coaching studies, 19 of these were randomized trials, moderate but significant improvements in evidence-based care. Oh, here was the piece that Lori was referring to. In a study comparing practice facilitation to self-directed studies, this is that national demonstration project from TransforMed. I was looking for this slide. Modest improvements compared to self-directed, so the self-directed sites, they got together and did their own QI. In adaptive reserve, so places that had coaches had more adaptive reserve, which is more ability to make change. And they also implemented more of the components of the medical home, the ones with coaches, but the outcomes were about the same.
You know, I feel like that's an actually really important point to bring up.
It
That's
is.
another thing that we talk about a lot, especially with smaller practices, that they don't necessarily feel like they have the capacity to have an on-site, and I'm thinking of like an on-site in-house kind of coach whose job it is to really think about quality improvement. I think that's a tough argument to make, and I feel like that's a place where I'd like more assistance in helping organizations feel like they can invest in that for the long term and that it will be worth it. Because that's really different than the traditional model of focusing on providers and the staff who are supporting them. And it's just something that we haven't talked about as necessarily being a core. We talk about the quality improvement strategy being important, but actually tying that to then a person to run the work is, maybe a place we need to go next.
Right.
Thinking about the models.
Right. Other comments? So there are a lot of questions that remain on all of these areas, and some of these are the meaty questions that we want to know, and some of these would be lovely if you guys are doing medical home interventions, and if you are lucky enough to find funding for an evaluation, I am putting my plug in now that these are some questions that I would love to find answers to because they are just not out there and we don't know. Does intensity matter, right? Can you do distance? Can you do 5 webinars? And is that the same as bringing people together face to face? Because if it is, we should do that because it's a lot cheaper, right? Or does it matter? Is intensity, how do we measure that? And does it make a difference in terms of outcomes? What about duration? Do you have to have an ongoing relationship, or can this be a time-limited thing? Can we do a year and see improvements and they sustain over time? I'd love to know. Approach. Do you need like the guy who knows everything about eClinical Works to come in and Crystal reports? And that is what you need. Or do you need someone who knows a lot about primary care and connect you to a variety of resources and help you out? Which is the approach that we should be investing in? A lot of specialists or a generalist? What about qualifications? Are these people that have good social skills and people skills and we can train them to be a coach? Or are these PhDs with a lot of experience and or, MBAs, and they've been in practice for 100,000 years and are old, medical directors, and those are the ones that do a great job? We don't know. I mean, I don't know. I feel like I don't know, and I want someone to find out. But these are questions, and there are a lot of questions about how we structure coaching. So to your point, we don't get paid to evaluate these things, but if you have a chance to deliberately look at or capture these things or write them down, you will have an audience, at least in me, in working on it. And this was one of the last pieces I wanted to share about this coaching. And we were talking about assessment tools. We were talking what's a predictor of success. We were talking about leadership. How do we know how to get more teams, more of those 30% success teams? And this is an interesting pyramid developed by a practice coaching network in LA who talks about the sweet spot of what kind of practices you want to work with. We usually work with these guys, right? These are the ones that volunteer. This is Virginia Garcia. These are the people that are like, we will do our thing. We will do our thing whether we have help or not, or money or not, or whatever not, because we are amazing. Then there are some down here that are like, I'm doing my paper records, and my daughter is the front desk staff, and we're trying to figure out claims. That's not a joke. We work with those practices. And you're like, let me help you with your, registry. They're like, awesome. Could you also help me get paid because I haven't taken home a paycheck in 2 weeks? This happens, right? These are not the practices that are going to benefit. These are not they're not going to benefit much. These are the NDP projects, the Transfer Med practice. They're going to do their own thing without. These are the ones you want in here that have administration, clinical systems, QI systems, and connections to outside networks, but they're in the middle. They're in that sweet spot, right? They're in the middle where they have some room to improve. You can help them in some areas. I hope you can help them in leadership. I'd love to know how. But you can invest skills, you can invest knowledge, you can invest resources, and it's a more or less fertile ground, and you could see changes. So this is kind of the area when we think about working with practices, and there's a huge literature on assessment tools that I should have brought, but we can talk about. So what has worked in this kind of thinking? What has worked and what's been really challenging around coaching practices? What have you noticed about the practices that you've coached that have been successful? And what have you noticed about the ones in your own experience that they haven't gone anywhere? Because I know we all have those stories. I have like PTSD memories from some of these experiences, right?
Someone in the practice has passion.
Someone feels the fire, right? I'm assuming that's for the transformed practices, right? Yeah, right.
They want to go somewhere. They're maybe not quite sure where they want to go, but they have passion to continue to improve, and it's centered around their patients.
Does it have to be passion, or do they have to also engage?
Well, they see they want to go somewhere. So somebody's ready to take that risk and make change of some kind. And it could be little kind of change, or it could be big change. But somebody, and Michelle and I were just talking about this, we're kind of fortunate from the standpoint that we don't have to make anybody do it. Yeah. We can tell them what their opportunities are and why they should be doing it. But then if they choose not to respond to my email, I look back in 6 months and, we see where they're at.
Is anyone in a position of having to make people do it? God bless you. Anyone? That is just not a joke.
Yeah.
Right?
So we're kind of the consultants that are available and can help them, but they make that choice in a sense.
So they want to engage.
Yeah.
What else? Characteristics of high-performing practices.
adding on to that, and I was thinking that they're fundamentally unhappy with the way things are, and so therefore they want to change.
Isn't discontent great?
Yeah, it
It's
really
great.
is. The people that are skeptical and unhappy, those are the people that are going to be motivated to do then what's next to change.
Right. You're like attracted to the ones that are already functioning and brilliant and wonderful, but it's those ones that are like, this isn't working, this is broken, that you're like, yeah, right? What else?
Again, building off that, it's folks who, and you're understanding why they do it. So, and usually it has to be motivated around the patient. So they got into the work to give good patient care. They don't feel like they're giving good patient care. They see the holes and the gaps, and that's mostly what they see. And so they want to fix those things, but maybe don't know how or what to do. So, but understanding why the work is important, why what they do to change that might actually make a difference in people's lives and their health.
Interesting. What else? Yeah.
I think connecting practices to each other works really well in terms of them being able to provide each other with moral support, to be role models, to share good ideas, to share lessons about what hasn't worked. And also because we have so many answered questions about what attributes of practice facilitation really make a difference, when you have peer learning and peer connection, then that's not really as consequential, because it's not as much about the practice facilitation and the coach, but more so about the collective wisdom in the community, and they have the relationships to access that from each other rather than having us as a intermediary.
So this is interesting, right? There was a program called Improving Performance in Practice. It was funded by the Robert Wood Johnson Foundation, and their thing was that they were going to only provide practice coaches. And the coaches were going to go out and they were going to work with the practices. And about 8 months into that initiative, they said, you know, the teams that were doing this work said, we'd really like to have some funding to do some peer-to-peer learning. We think that might be helpful. They're like, no, we're trying to develop this low cost, super tailored, really helpful. Practice doesn't have to close down. It's really going to be about connecting, meeting the practices where they're at, just one-on-one. We're going to do that. That's kind of what the game is. I really kind of think maybe we should do some peer-to-peer. And they got funding finally to do some of this peer-to-peer learning. And there is this sense, and they didn't evaluate it, but there is this sense that having a facilitator and providing opportunities for peer networking in a deliberate way makes a difference, right? So there's the learning collaborative literature. One of the things that was super cool about the Safety Net Medical Home Initiative, and one of the biggest surprises, that when we asked sites what was the single most motivational thing that they did, they said site visits. Two kinds of site visits. One kind of site visit is the practice that is completely unmotivated and you're trying to get them going, right? And you send them to a practice. Doesn't have to look like them. Doesn't have to look anything like them. Just has to be excellent, right? So we sent these like small rural docs up to group health. And they were like, oh. That's what we're talking about. I can see it now. I see the vision of the medical home. I understand it. I can work toward it. So there's the motivational site visit, but then there's the I cannot figure out how to get the after visit summary out of eClinicalWorks. Please, somebody, how do people make that work in their practice? And that's let me find a practice that looks just like you, that has your same EMR, that where you two can talk through the really operational details. Two different kinds, two different needs. But when we asked, they were like, who's ever heard of funding site visits, right? Like as a sustainable QI method. This is something I want to gather data on, was far and away, repeatedly, the most important thing site said was helpful. What else? Yeah.
One thing I think we've all found is you go into sites and people actually want to do great work. I mean, they really want to improve the patient's lives, which is an incredible place for us to work. I just think that's so exciting. And very often it seems like when you put data, plausible data, in place and they realize they're not where they wish they could be for the population they're serving, there's a high degree of motivation. And I think combined with empathy, which I think this group is good at, is it's okay. It's okay. We don't know what we don't know until we know it. Right. And now here's the first tool. So I think, and it's so much like patient care, but it's like staff care. It's just, how do you embrace the fact that people actually want to offer great care, as opposed to flogging them with how poorly they're doing.
Right.
And I think, it's just these pieces we said, you bring data to the table and embrace their desire to change.
Yeah.
Even when there's pushback.
Right.
There's still a desire.
God bless turnover on some of these cases.
So I think one thing that's challenging, and it's part of what makes it work, is facilitating the process of managing drivers and what's driving the change.
Right.
There's obviously internal drivers, we want to do better for our patients. And then there's external drivers, which is the system and the payment, reimbursement structures and all these things that they weigh into the decisions they're making. And it's beyond just wanting to do better, but like your kind of steps of things to do first. Well, if you can start getting paid for care coordination in some ways, I'm going to start there, even though I'm not going to get paid to work on a team or a panel manager or these. So that comes into the conversation an awful lot. And so and I think it's part of why some prices probably retract back to their old ways once projects are over and things like that, is that they're still operating in the system, and some of these improvements that we talk about that's better for the patient, and better for satisfaction, are kind of upstream to what the system is and what they continue to exist in.
How do you as a coach keep on top of all this environmental stuff going on?
Yeah, it's definitely difficult. It's conversation, and I think one of the things about talking about what practice facility or a coach isn't, there's no script for it.
Right.
I mean, there are skills that allow someone to be good at it, and I think like critical thinking and good conversation skills and things like that. But one of the things that I try to do is actually bring up drivers. When I'm like, why would you want to start there? That's interesting. You don't have a UI process. Why do you want to start with care coordination or shared care plans or something really hard that kind of, and you figure it out. I mean, you can get to it, and maybe you don't always figure it out, but they exist, and it's a challenge because there are many things that go into people's decision on what they work on as a team, as a practice, and engaging leadership. Sometimes you have to kind of use it, encourage based on a driver that maybe you wouldn't think is a good place to start, but it's how you're going to get that leader engaged.
Right. You guys say something?
I think getting yourself in the door. So, I mean, that's
Right?
key. I mean, you have to get in the door first. You got to have that opportunity.
That was the single biggest problem in our APCP demo. People couldn't they didn't know who to call.
Right.
They couldn't get in.
Yeah.
You're not kidding.
No, I'm not kidding, because if that office manager doesn't like you, you're not getting an appointment.
Right.
They're not going to answer your call. If that doctor who owns that practice is not on board, you have to find what that carrot is for them. So it's a matter of finding your in. And I think that's what you were talking about, is maybe your in is reimbursement or the ACA payment that's only for another couple of months or whatever the case may be, but maybe that's my in for now, and then you can navigate your way. But I think just having that champion or that person with that passion is key, but it has to be coupled with the stakeholder or the decision maker of the clinic also, who's going to help with that culture change and that setting those expectations once that and following through with those expectations. But if you never make it in the door,
Doesn't matter.
yeah.
Were you gonna say something?
Yeah, and I think too with all of this stuff, it's also that sense of reality where a lot of times you get in the door and they say, our patients are so much sicker, or our system is
Has anyone
so
ever-
much worse. I
never hear that.
For me, it was amazing working with a group of dentists that they said, well, we can't do, unlike every other provider, we don't have a good source of data in an EMR. And I said, well, actually, mental health providers, it's even harder for them, and talking about 42 CFR. And after that, they were like, oh, well, then maybe we can do it. And it was like not feeling like they were the ones that were left out, or that they were always, it was, no one's been
No
handed
one's figured this out, and you're the
Right.
last man standing,
Right.
right?
And it was that if this is reality, here are resources. So going back to that idea of kind of what is the coaching of education, knowledge, and skills, it's also like reality. How you are viewing the world is not necessarily what's really happening, and it is in some cases. It's barriers we all share, and how as a group we can address those barriers instead of letting it keep people from moving forward individually.
Yeah. What else? Yeah.
I think one thing that's worked and been a challenge, and I'm sure Brooklyn can share, is we started One Learning Collaborative before the patient-centered medical home effort was released, and then we've had this other Learning Collaborative after. And so what has worked is we knew there was going to be political momentum around it, right? But what has been a challenge is that, the fundamentals of medical home require like fundamental change. Like if you really do it in the way it's
Epic
meant
wholesale
to be.
reimagination, as our friend Paul
And-
Nutty would say.
And it's not a fault of the program at all, but there are some practices that just want to certify and like, okay, we're done. And so while it has been this hook, now that it's actually kind of, if you talk to even Jeannie McAllister from Center for Medical Home, she says like the whole tone of medical home improvement now is different because it's tied to payment. So before people did it and they did self-attestations and they were thoughtful about it because they were trying to become a medical home, not because there was no payment.
But this is your point, right? These people were driven by internal motivation. There's only so many of those. What a blessing that we now have some external motivation that's bringing some people in, but they need to be worked with in a different way, right? You come in with the hook of recognition or certification, and you have to draw the connection to transformation and why it matters. Where those internal motivation folks, they went about transformation, and the recognition was a thing on the side. But recognizing, right, what is the driver, and it's different. And if we only worked with the internally motivated, it'd be awesome, right? You don't have to do that work. But there's only, they're the top of the pyramid. So it's, right?
You can get certified and not actually transform.
Totally.
So that's a little bit of the hard part is that the hook, which is great, I'm so thankful that we're in a state that has the hook, is also potentially, we might not get the people to do what they need to do because they can get away, they can get away, I don't know.
Right. Well, and that's part of seeing when you do go on site and obviously I have this opportunity, you actually are able to sort of figure out, sort of the depth at which they meet the things that they say that they're doing, whether it was a checkbox, whether they were like, oh, actually I didn't really understand that at all, or whether they went way past that checkbox to really transforming. And when you're talking to them about the work that they do on site is really when you get that opportunity to do that when you guys do and when I do as well. And when you see it working, again, that's a self-motivator for them, although they don't have the context to say, we got this working, how do we compare to other people around us? And so, again, feeding that back to them of saying, well, this is what we see, and you guys are actually really far out in front, so this is a really positive thing, and here's some things that we're seeing that you're not doing that you can incorporate is really a valuable learning for me and for the practices, I think, as well.
I was gonna say, I think that's part of the tricky dance that we do as coaches of that, I like that relentless contextualization. Like you're taking what the hook is that they have self-identified. And I think we're fortunate in Oregon because of all the hooks. There are a lot of people who have something you can hook onto. But then going back to your stages of what's easier to do at a foundational level is tying that hook to something foundational that they can build and figuring out how to start from there. Because you can't initiative your way out of this. You can't just do a series of projects and have transformation happen. It has to be linked to those fundamentals. So how you tie the hook to those fundamentals in the moment in the conversation with leaders is the dance I think we all do.
Right. Yeah.
We have the overachieving sites that have been at it for a long time that understand the devotion of why this is the right thing to do. And then we have the newer sites that by the time they were certified in 2011 had been kind of transforming for a year to 2 years, and they're like, okay, we're just the same as everybody else, we don't need to work on this. So trying to identify what is the hook for those particular practices, and then trying to kind of get beyond the understanding of we have great senior leadership support from our system, but getting that middle leadership support of the clinic manager trusting us to come in, and their staff wants to make changes and their staff sees what needs to be fixed and they're engaged, but the manager is like, I've built the best mousetrap ever, why are you changing me? We're the same as the rest of them, why do we need to change? So trying to find out walking that kind of fine line in between the two to get them to continue to move forward.
Like one of the challenging areas that I don't know how to get beyond is when there's a community where there's an external influence on the practice. I'm going to be very careful about the words I select. That the practice has a very strong relationship with, that's not really supporting them to do to transform and not really helping them to see that vision. So I can understand maybe a year ago for PCPCH, you kind of wanted to see where this was really going, but now here we are today, and there's just not that burning platform that's conveyed from their local community, and that is just and in those communities, what I hear back is that all of the doctors there are these small independent providers that are going to retire soon.
Yeah.
So we apparently in Oregon have a lot of those.
I am telling you, the theme of the QI conversation is turnover.
How do we get people?
One more thing I think has been a real challenge is, a lot of the things like Breakthrough Series, collaboratives and things, when you're talking about a very specific topic, like developmental screening
Asthma.
asthma,
Right,
diabetic care, it's just a different process.
is,
When you
it
start talking
is.
about medical home, you have a year, you barely even get over team and developing essential meeting skills before the years. So some of the models that exist for quality improvement, at least in their existing form, don't really match to.
You are exactly right.
So trying to make that fit.
This is a new ballgame. The reason this conversation at this state, which is one of the most innovative in the country, with all of you here, is so amazing, is that the patient-centered medical and patient-centered primary care home is totally different than any asthma collaborative, diabetes collaborative that we have done. And it requires a different level. I mean, it is, Paul Nutting, epic wholesale practice reimagination. Right? That's what the words he uses to describe what a practice has to experience to change the totality of every process, the scheduling process, the rooming process, the roles. I'm the doctor, this is what I'm supposed to do. Oh, no, it's not. Right? Everything changes. Well, what are we supposed to do as coaches, right? Our role has to be radically transformed as well. What kind of peer-to-peer learning works? How do we go into practices to make that? How do we motivate and bring people along? What do we need to know about mid-level managers? You don't need to know about mid-level managers with an asthma collaborative. I mean, you do, but not at this level, not at the level of hey, I'm asking you to upend your entire practice. What about that sounds good to you that I could help you through that? You know what I mean? It just, so my hope, and I will just say this, and we'll have time for more conversation in a minute, but I will just say my hope is that this group would go on in some way to become your own learning community, right? So that you could share and learn from one another this entirely new way of supporting practices on this entirely new journey that they're doing. I mean, they can do certification alone, but we, I think, all want it to be about more than that. So I'm just going to share here, you'll get these slides. There's a bunch of resources for you, for coaches in particular. The Agency for Healthcare Research and Quality put up how to set up a coaching program, how to evaluate one, what metrics you should be tracking on your clinics to see if they're improving. I brought a tool for you guys called a tiering tool that was developed as part of the Safety Net Medical Home Initiative that can help you categorize where your practices are in terms of motivation and what things you might do to help move them along in that way, and we'll distribute that. We just developed coachmedicalhome.org, which is lessons learned from the Safety Net Medical Home Initiative about the radically different role coaches have to take in coaching medical home versus other previous QI efforts. So there's stuff here. And I just wanted to close with this quote, because a lot of what we're talking about is, to do things differently, we must see things differently. When we see things we haven't noticed before, we can ask questions we didn't know to ask before. And that is our job, right, as coaches with the medical home, is the presentation of new information to help our practices see things differently and ask new questions and explore with them. So thank you very much, and we'll have more time to talk.